Hello and good morning. So I hope you had a great week gone by and a great weekend as well. I had a wonderful weekend. Yesterday I finished a very interesting book. I have been trying to kind of get my head around that book for the last 2 3 weeks. It's a book called Quantum, about quantum mechanics, but not really the mechanics part of it, but about the people who were involved in discovering the world of quantum. How did they go about doing it? A little bit about the physics also, but the physics is, well, what can I say? It's beyond at least me to understand what they're trying to say, but it's very interesting nevertheless. The idea about how the microscopic world, or other a world that even a microscope can't see, how does that world behave? It's really interesting. The questions of what is real, what is not real, it's really interesting. So those of you interested, I'm sure that some of you must be those students who in your before MBBS started were interested in physics. I was very interested in physics. It's been some time that I've been trying to go back and read some parts of physics. You have the time right now. Why don't you try it? It might be a good idea to go back and read all those topics which you thought were interesting, but you never had the time to. I mean, let's be honest. You have a lot of time right now, and a lot of that time might just be you doing nothing productive. So might as well go back and read that. Right? Think about it. So welcome back to today's lecture. Today we are going to talk about a very interesting topic and also very fundamentally important topic in managing a lot of patients coming to you in the emergency or in your wards or sometimes in the OPDs. We are going to talk about coronary artery disease, and as we do that, today's lecture is not going to be a very long lecture, but nevertheless one of the basic foundational lectures on which you are going to tomorrow go and understand your patients. It's unlikely that whatever I'm going to talk of today is ever going to come as a question to you, right? This per se might not be a question to you. But nevertheless, you not understanding this would mean you will take a lot of wrong steps tomorrow when you see patients, right? So pay attention, stay with me. If there are questions, do ask. We are going to start with what is coronary artery disease and how do patients present to us and what are we supposed to think when the patient presents to us, right? So what happens when you meet a patient having coronary artery disease? We are going to start from there. If you are reading coronary artery disease from any textbook, in all possibility, the format is very different from the way in which I'm going to go around that topic. In most of them, you will find it distributed amongst 2 or 3 chapters, coronary artery disease. We will cover all the important factors of all of these chapters, but the format would not be the same as it is going to be in your textbook, right? By now, you have figured that out. That's how we are working at Quest, at anything that, it's more important that we understand how those textbooks apply to our patients. So here also, let's try to do that. Let me start by giving you a case. It's actually a thing that I would want you to see and maybe commit some answers of your own to this. Okay. So let's say you are wherever you are right now in some hospital, and you have a 38-year-old man who has presented with sudden onset retrosternal chest pain, and this retrosternal chest pain has lasted for last 1 hour. He is normotensive. When you examine him, the chest is clear. His CVS examination, you find that the heart sounds are a little soft, but you cannot find any murmur. In the next slide, I'm going to show you the ECG. The assignment is very simple. What you need to do over the next 2 to 3 minutes, sorry, is that you need to tell me how do you plan to manage this patient, right? This is the ECG of that 38-year-old man. These are, just in case it is not clear, this is lead 1, lead 2, lead 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. This one over here is lead 2. It's a long lead 2, the same lead over here, but it's been taken for a long period. So it's long lead 2. I know that we have not discussed ECG with you yet, and it's fine. I mean, even if you make a mistake, that's fine. When I say manage, manage means at least 2 things. Think about investigations that you would like to ask. Think about the treatment plans that you would like to start. So I'm going to wait for the next 3 minutes. I do not want you to send me your answers. Do not post up your answers. Write them down somewhere. Commit to some answers so that by the time this discussion ends, this won't end today. This would end in the next lecture. By the time this discussion ends, you know where you started from and where have you reached, right? What new did you understand over a period of next 1 to 2 lectures, right? So please write down. I'm going to hold on for the next 2 to 3 minutes. This is the case. And this is the ECG. You don't need to send me the answer. You need to write it down somewhere, maybe the back side of the book that you're writing on, so that you commit to some answer and you can kind of assess yourself how much on track were you when you started seeing this patient. Last half a minute maybe. Okay, so let's start with the idea of coronary artery disease. Now, there are a few things that we need to understand. So I'm not going to give you the answer right away. We are going to think this through as we go ahead. You will try to fit this patient into one of the scenarios that we are trying to understand and then come up with the answer, right? So let's start with coronary artery disease. First things first, how is a patient of coronary artery disease actually going to present to us, right? So let's start with some basic idea about what do we need to think of when we are thinking of coronary artery disease. Let's start writing that down. So please make a note of this. What are the clinical features of a patient coming to us with coronary artery disease? Please make a note of this. Coronary artery disease is the new section that I'm starting. Coronary artery disease, also what was earlier known as ischemic heart disease. Just give me a second, please. Okay, so I hope my audio is very clear. If there is any problem with the audio, just send me a message, right? If there is a problem, then send me a message. Otherwise, do not type. Okay. So, when we are talking about coronary artery disease, the older name for this was ischemic heart disease or IHD. That name you can still use some, I mean, you'll find some examiners still using the word IHD, but now the better term is coronary artery disease. What you basically mean in coronary artery disease, please understand and make a note, is that there is a demand supply mismatch. So when we talk about coronary artery disease, we are trying to understand that there is a demand supply mismatch, right? Demand of the myocardium and supply by the coronary arteries, there is a mismatch between them. So either the demand has gone up or the supply has come down, right? One of the two things has happened, maybe both of them has happened, and because of that, there is a resultant ischemia to begin with. There's a resultant ischemia to begin with. Or if it is a prolonged ischemia, now you understand that ischemia means there is a reversible damage, right? So ischemia means there is a reversible damage. But if there is a prolonged ischemia, there is a prolonged decrease in blood supply, prolonged decrease in oxygen, that area would die, and that is called infarction. That is called infarction, which would be irreversible. Right? But at the heart of all of this is this idea that there is going to be a demand supply mismatch. Depending on how long that demand supply has the mismatch has remained, how severe it was, you might have ischemia or you might have infarction, but the problem is a demand supply mismatch. The increase in demand, there could be some reasons why the demand has gone up. So please make a note of this. The increase in demand could be of multiple reasons, but common reasons why the demand has gone up is maybe the heart is overworking. For example, there is an increase in heart rate. Someone having arrhythmia, someone having sinus tachycardia, heart rate has increased, so the demand has increased. Maybe there is a requirement for increased force of contraction. There is an increased force of contraction because of some reason. That reason could be something like opposition, like hypertension. That reason could be extra work to do, like volume overload. There could be an increased demand because the muscle has gone up. It could either be a hypertrophied muscle, hypertrophy of the LV, or it could be a dilated muscle, which again means the overall mass has gone up. Right? So it could be an increased heart rate, it could be an increased force of contraction, basically associated with increased sympathetic drive, hypertension, volume overload, hypertrophy, or dilated heart. Right? It could be one of them, or it could be all of them together, or at least multiple of them together, right? So we have to look out for this happening to our patient. But importantly, in fact, much more important than all of these is that there is a decreased supply, right? So please make a note of this, that the most common cause of coronary artery disease is not that there is an increased demand. This is very often there, but that's not what brings the patient to us. The most common cause is there is a decreased supply. And when I say decreased supply, there is a decreased blood flow through the coronary arteries. There is a decreased blood flow through the coronary arteries. And when I think about coronary arteries, I know that there are three of them. There is technically right and left coronary artery, but further I would have the two branches of the left. So I can have the left anterior descending, I can have the left circumflex, and I can have the right coronary artery. So there is a decreased supply to either the left anterior descending, left circumflex, or the right coronary artery. Right? And the coronary artery disease, that is why we call it the coronary artery disease. We don't call it ischemic heart disease always. We now prefer the term coronary artery disease because in most of the cases there is a problem with the coronary artery disease. Depending on its severity, it could present either with ischemia or with infarction. Depending on the severity of the coronary artery disease, patient can present either with ischemia or with infarction. Right? Now, please understand, this is what is happening at the background. This is maybe the pathophysiology of what is happening to the patient, right? But the patient is going to come because of these features, and these two are going to have some clinical features. So the clinical features that I see are happening because the myocardium is having either ischemia or the myocardium is having infarction. Now, I want you to understand that the clinical features of ischemia and infarction, if you ask me what will happen to the patient, well, perhaps the same thing will happen if the patient has ischemia, the same thing will happen if the patient has infarction. What will differ is the severity. Remember, it's the same pathophysiology which is carried forward. An ischemic heart can become infarcted, right? So it's not necessary that all ischemia should convert to infarction. It depends on how prolonged it was, how severe it was, was there a collateral supply, so on and so forth. But an ischemic heart can become infarcted. So it's not necessary that the symptoms would be new. It's more likely that the symptoms are going to be more severe and more prolonged. So please make a note of this, that clinically, the features of ischemia and infarction are overlapping. You might not be able to see a patient and say, oh, this symptom is equal to ischemia, that symptom is equal to infarction. You might not be able to do that. Right? Clinically, the clinical features of ischemia and infarction, they are overlapping. What is different, of course, is that infarction is going to have more severe symptoms, more prolonged symptoms, right? So this is going to have more severe symptoms and it is going to have prolonged symptoms. And of course, we understand this idea that it is irreversible, which means it is going to cause damage which will last for a longer time, right? But when the patient presents to us, you might be having a tough time to differentiate them. So we will have to pay attention to what that severity means. We have to understand what that prolongation means. We'll have to pay attention to this. Right? So what are going to be the clinical features of coronary artery disease? So please make a note of this. What are the clinical features of coronary artery disease? Who is this patient who is going to come to me with coronary artery disease? When should I suspect that my patient has coronary artery disease? Now, I'm not going into the types of coronary artery disease yet. I'm telling you what is overall going to be the presentation of a patient having coronary artery. Well, to begin with, men or women? Men or women? Well, it's going to be men more than women. Right? It's predominantly a disease seen in men compared to women. The age is going to be anything more than 40 years. So remember, our patient is 38-year-old in this case scenario, but most of the patients who come to us with coronary artery disease would be more than 40 years. That does not exclude that it can't happen in less than 40 years. So I have had patients who are 28-year-old, 25-year-old who have come with coronary artery disease, and that's kind of increasing now. The awareness is increasing. I have had a batchmate of mine who has had a MI. So when we were doing residency, so it's that early that we have seen MI coming up. So it's not necessary that it should always be more than 40 years, but most of the cases are going to be more than 40 years. And in fact, in most cases, the patient is going to be around 50 to 55 years old when the first symptoms start, right? So they're going to be more than 40 years, yes, but they're going to be very often in this age group of 50 to 40, say 55 years when the symptoms start, right? ये जो male more than female है ना, this is a very interesting one. So the idea is that we understand diseases by looking at its effects. So there is no such thing that I mean, God ने भगवान ने बताया था कि men will have more of coronary artery disease and women will have less, and then we are saying, okay, it's written by God, so we are going to follow that. It's not like that, right? Of course, you understand. We have observed what is happening in the community, and we have said, oh, okay, patients coming to us with so and so features have coronary artery disease, and they are turning out to be men. That is what we are teaching you. But what we kind of tend to not tell you very often, because we also did not know it for very long, is that the initial trials which were done, understand a lot of this is coming from trials. It's all, in fact, cardiology is heavily trial based. So a lot of these things, when they were tried out initially, the trials were done in the Western countries at a time when it wasn't very common to enroll women into the clinical trials. So we have done clinical trials at a time from where we borrow this data when women were not included in the clinical trials. If women were not included in the clinical trials, you have included men in the trials for coronary artery disease. Well, it's most likely that you're going to see men coming with coronary artery disease, isn't it? That's logical. And still worse, it's also possible that what you thought were the symptoms of coronary artery disease, you have seen them only in men. You have seen some other features coming in women, but since you did not systematically study them at that time, now you end up saying atypical features happen in women, right? I'm not saying this is always the truth. This is not the complete truth, but this is a part of the truth that you should be aware of. So please make a note of this. Increasingly, we are finding that a lot of women are underreported, right? There are women who have coronary artery disease, but the bias that has gone into at this stage, when we are teaching you, the bias that goes into your head that, okay, it's going to be men, kind of tends to blind you, right? Don't let that interfere with your practice. Tomorrow, when you see patients, if you see a lady, it's likely that you have not thought of coronary artery disease just because she was a lady, right? Don't do that. Ladies or women can come with coronary artery disease, and make a note of this. They might have atypical features. Quite honestly, it might not be very correct to call them atypical features, because maybe they are typical features in women, which we just did not happen to study early in the course of cardiology, right? So whatever that truth might be, remember that this is not the whole truth. It's not completely true to say that men are the ones who are going to have coronary artery disease and women are going to have less of it. There is some truth. Yes, overall, I still feel men get more diseases than women as far as CAD is concerned, but women having CAD is possible. Right? We'll see what the typical and atypical features are, but this is a kind of a trivia, you might say, that I feel you should remember. Next, in the clinical features, always remember that you are looking out for risk factors. So these patients would have history of one or the other risk factor. Now, some of the risk factors are here, that is the age and the gender. But apart from that, patients can have other risk factors like family history. So please make a note of this. In your history, when you're taking history in case of coronary artery disease, there are other concerns that you have, like the patient might have a family history. Family history of what? The patient would have a family history of coronary artery disease. That means his parents or his siblings have had coronary artery disease. But there could be a coronary artery disease equivalent. Remember that coronary artery disease means you have blocked the coronary artery, of course. We have just in the last section understood that you might have a blockage of another artery, the cerebral artery or cerebral arteries leading to stroke. So it's possible that the family history is not of this artery getting blocked, but some other artery getting blocked. So don't forget to ask the question, is there a family member having stroke? Please remember, both of them from pathophysiology perspective are quite similar. Both of them are diseases happening because of atherosclerosis. So I have to remember to ask for this family history. Don't forget to ask for family history of other conditions which are very high on the list as risk factors, that is diabetes and hypertension. So we are looking for family history and we are going to ask for these questions. We have other risk factors like diabetes mellitus. Please mark this as important. If someone is to ask you, tell me the one risk factor which carries maximum risk of doing coronary artery disease, the answer is diabetes mellitus. So please make a note of this. The one risk factor which has the maximum risk of causing a patient to land up with coronary artery disease is diabetes mellitus. The second risk factor, second only to diabetes, is smoking. Please mark this as important as well, that the second risk factor which is equally important is smoking. Apart from that, patient could have other risk factors, like the patient could be hypertensive. The patient could have other risk factors, like the patient could have dyslipidemia. When I say dyslipidemia, that means the patient could have an increased LDL, could have an increased triglycerides, could have a low level of HDL, right? Dyslipidemia would mean this combination: increase low density lipoprotein, increase triglycerides, decrease HDL. It's worthwhile to remember, when I say increase LDL, I mean a value of more than 130 or a value of more than 190. If the patient is diabetic, a value of more than 130 is taken as significant. If the patient is non-diabetic, a value of more than 190 is taken as significant. When I say triglyceride, I mean a value of more than 150, irrespective of the diabetic status. And when we say HDL, it should be low because it's a protective one. So having it low increases the risk. So an HDL of less than 40 or less than 50, less than 50 in women and less than 40 in men is considered as high risk factor. Right? Patient can have one of them, patient could have all of them, depends. So we are talking about the risk factors. Patient could have diabetes, patient could be smoker, patient could be hypertensive, patient could have dyslipidemia, patients could be obese. Other risk factors could be that the patient is obese. A related risk factor is perhaps the patient has a sedentary lifestyle. You need to ask for the occupational history. What does the patient really do? I mean, the patient might say, I'm a banker, and then you might assume that he has a sedentary lifestyle. Not necessary. Please ask, what do you really do? When you're a banker, what you don't understand all the professions, do you? So you need to ask them, what exactly is your day like? Are you sitting for long hours? Are you in meetings for long hours? Are you walking out on the field for long hours? What do you really do? Right? So ask for this specific idea. What is their occupation and how is their daily lifestyle? Do they have a sedentary lifestyle? Right? Stress. If the patient is someone who has a stressful lifestyle, that is also something which is going to be contributing towards risk of coronary artery disease. There could be other less commoner associations, but these are not to be missed. These are the topmost associations apart from age and gender, which we should be thinking of. Right? With a background history of all of this, the cardinal features with which the patient presents to us are four. So please make a note of this. Typically, the patient would present to us with angina. We are talking about clinical features. So typically, the patient would present to us with angina. Patient can present to us with dyspnea. Patient can present to us with palpitations. And patients can present to us with syncope. Sometimes patients might also present to us with just fatigue, especially elderly patients. So we might have some elderly patient who doesn't complain of all of this, but just complains of fatigue. I'm feeling tired, right? Before I move towards angina, it is easy to understand, so please make a note of this, that dyspnea means that the patient is suffering from. Why is the patient dyspneic? If the myocardium is not functioning, if the myocardium is not getting its blood supply, why is the patient developing dyspnea? In all possibility, because the heart is not pumping well. If the heart is not pumping well, that is causing backward failure, that is causing dyspnea, which means the dyspnea should be considered as a marker of heart failure. Remember, we have said that the commonest cause of heart failure worldwide is coronary artery disease. That is what I'm saying here. That the patient could have dyspnea, and that dyspnea is a feature of heart failure. Palpitations, easy to understand that the patient might have developed arrhythmias. And typically the arrhythmia I'm afraid of is always atrial fibrillation. It is at the top of my list. The most common pathological arrhythmia is atrial fibrillation. Patient having syncope, syncope मतलब मुझे चक्कर आ रहा है. Patient having syncope or fatigue, both of them are features of again heart failure, or what you might find easy to remember as forward heart failure, right? So though the term forward heart failure is now outdated, but it's easy as a concept to remember that the blood isn't being pumped out. So the heart is not pumping enough blood out, the stroke volume is low, so the patient is feeling dizzy, so the patient is feeling tired, right? Please make a note of this. Under appropriate circumstances, if you have the relevant situation. Now, what that relevant situation is, we will try to understand as we go ahead. But under appropriate circumstances, please make a note of this. Dyspnea, palpitation, syncope, fatigue. These should be treated with equal importance as we treat angina. So they are called angina equivalents. Angina equivalent. So please make a note of this. Dyspnea, palpitation, syncope, and fatigue are also known as angina equivalents. That means they should be given as much importance as we give to the symptom of angina for diagnosis of coronary artery disease, right? They should be given as much importance as we give to the symptom of angina in patients of coronary artery disease. And in some cases, these angina equivalents may present without angina. That means you might have a patient having dyspnea and angina. That's possible. Then it's easy for me because I saw angina, I understood angina, and I thought of coronary artery disease. But there is a possibility that a patient came to me with dyspnea without angina. At that time, it might be really tricky because you might get carried away and feel, oh no, this is heart failure, but is it coronary? I'm not sure. So that time, don't forget that it is an angina equivalent and it can occur without angina. And such a scenario of having angina equivalents occurring without angina, so one of these coming without having angina, such a scenario commonly occurs in patients who are diabetic, patients who are elderly, and in a lot of women, right? So please don't forget this part, that angina equivalents should be thought of independently as the presenting factor of coronary artery disease, especially if you're looking at elderly patients, especially if you're looking at diabetic patients, and sometimes in women. Right? We are trying to understand the clinical features of coronary artery disease, and I'm saying that age, risk factors, and with that, one of these cardinal features could be the presenting feature of coronary artery disease. Right? Of these, dyspnea, palpitation, syncope, fatigue are also known as angina equivalents. They can occur without angina, so we need to be on a watch out for them, especially in the appropriate settings. They should be taken as angina equivalent unless proven otherwise. Right? But that still leaves us with the idea of what is this story? What is angina really? Right? So please make a note of this. What is angina? Please make a note of this. What really is angina? Please make a note of this as I dictated. Angina is, please make a note of this. Angina is chest pain of cardiac origin or presumed to be of cardiac origin. At times you might not know really this is of cardiac origin, so you might have to be sometimes presuming, right? So please make a note of this. Angina is, the word angina means chest pain which you believe is of cardiac origin. Angina is chest pain which you believe is of cardiac origin. Now, there are certain factors which help you think that this could be of cardiac origin, and that those factors are the description of angina, right? So, how would the patient of angina present to you? Now, here, remember, I'm using the word angina as a symptom. In some time, you will find me talking about angina as a name of a disease, right? Now, understand, coronary artery disease has various diseases within it. It's a big umbrella diagnosis to say that my patient has coronary artery disease. Within that, you will have other diseases, right? So within those other diseases, you might find me using the word angina again. That time I will be using the word angina as a part of name of a disease. But here right now, I'm not talking about it as a name of a disease. I'm talking about angina as a symptom, right? So what are the features of angina, the symptom? When do I say that my patient is having angina? That my patient is having a chest pain of cardiac origin. Please make a note of this. What are the clinical features of angina? What helps me to think that this is angina? What helps me to think that this is of cardiac origin? Well, one, in most cases, angina would occur on exertion. So please make a note of this. In most cases, you will find that angina would occur on exertion. And it would be relieved. So it would occur on exertion and it would be relieved usually on rest. The patient would have angina, that is chest pain, which occurs on exertion and is relieved on rest, or on taking a tablet, which is, or medication, that is nitrates. So either relieved on rest or relieved on nitrates. So the patient would have chest pain on exertion, relieved on rest, or relieved on taking nitrates. Second, the chest pain would very often be retrosternal chest pain. Remember, the chest pain is not on the precordial area. It's not on the left side. Most of the times it is retrosternal, behind the sternum. So please make a note of this. The chest pain in most cases is a retrosternal chest pain. The chest pain in most cases it's retrosternal chest pain. This chest pain would radiate. It is not just one area, it will also spread to other areas. So this chest pain would radiate to certain areas. Very important history for us to ask, and this helps us to think, oh, this is the angina I'm dealing with right now. So the chest pain would radiate to certain areas like the left shoulder. So please make a note of this with me. The chest pain would radiate to different areas, like it would radiate to the left shoulder. It would radiate to the left arm, especially the medial aspect of the arm. So it will radiate to the left arm or the left upper limb, especially the medial aspect of the left upper limb. Hey, can it go on the right side? Can it go to the right shoulder? So it is going to the left shoulder, yes. But can it go to the right shoulder? Answer is yes, right? So please make a note of this. Very often we forget this. We think that it is a pain going only to the left side. Not true. So please make a note of this. The pain can also go towards the right shoulder and sometimes even the right arm, but it can very frequently go up to 1/3 cases. You might have the pain going towards the right shoulder. So it's not true to think that chest pain of cardiac origin is always the left side. No, it can go to the right side also, right? It can radiate upwards and it can come especially towards the jaw. So it's a pain that can radiate upwards towards the jaw. So it can radiate upwards towards jaw, which means it can radiate towards the neck and towards the jaw. It's a pain which can radiate backwards. So you might have a pain which is going backwards in the interscapular areas. The patient might be saying that the chest pain is here, but it's going backwards, right? It's a pain which can radiate downwards as well, right? It's a pain that can radiate downwards as well towards the epigastrium. So the pain can go downwards towards the epigastrium. But as we remember where all it can radiate. So it's a pain which is arising over here, but radiating here, up, back, down. But where would it not radiate is also important. So please make a note of this. Two areas typically that we remember it will not go to. is it will not go below the umbilicus. So please make a note of this. The chest pain of cardiac origin does not radiate below the umbilicus. It radiates up to the umbilicus at the max if it goes towards the abdomen, but it does not radiate below the umbilicus, and it does not radiate towards the trapezius. It does not go towards the trapezius. It goes up straight. It doesn't go like this. It can go here, it can go here. It doesn't go to the trapezius muscle, right? It does not radiate towards the trapezius. Please do not ask me why. I really don't know why it does not go to the trapezius. The root values are not very different, but I don't really know why it does not go to the trapezius. But it does not go to the trapezius, right? Helps us to identify that this is angina, right? So it's a chest pain which would occur on exertion. It would be relieved on rest or on taking nitrates, and it's a chest pain which can radiate sideways, upwards, backwards, or downwards. What's the nature of this pain? What kind of a pain are we looking at? Right? What would the patient describe? Now you have to ask these questions to the patient. We are taking this history, we are trying to understand how does it pain, what is the nature of the pain. Sometimes you might have to help the patient with some adjectives. Very often the patient will tell you what kind of a pain he feels it is. So the most common description that you will hear the patient telling you is that there is a retrosternal pain, which is a heaviness. So please make a note of this. What is the character of this pain? What is the description that the patient gives you? The patient very often tells you that the pain is of a heaviness. I feel a retrosternal heaviness. Right? It's very frequent for patients to say, मुझे लगता है किसी ने एक पत्थर उठा के रख दिया है. Right? They very often say that I feel that someone has kept a stone on my chest and it's as if there is some weight kept on my chest. Right? So patients do describe it this way, that मुझे लगता है किसी ने पत्थर रख दिया है chest पे. Right? So patients describe heaviness. They tell you that I feel that someone has kept a heavy weight on my chest. Now there was a patient who told me once, I feel like someone is sitting on my chest, right? So those kind of feelings is what the patient tells you. It's also sometimes suffocation that they're trying to describe. So you should be clear in asking the question, do you feel that there is a breathing difficulty or do you feel that there is a heaviness? Sometimes patients might not be able to describe them separately. So you should ask them further. You do know that dyspnea can coexist, right? So patients describe it as heaviness. Some words patients might use are crushing sensation. They might tell you as if something is crushing inside my sternum, right? So they might use the word crushing sensation. Heaviness, a weight kept on my chest, a crushing sensation. Can they tell me a burning sensation? Is that a description of angina? Can they tell me that there is a burning sensation? Jalan hoti hai? Can they tell me that? That retrosternal jalan ho rahi hai, burning sensation. Is that possible? Well, answer is yes. So please make a note of this. They might describe this as a burning sensation also, right? So please remember this, that the pain of cardiac origin can be a retrosternal burning sensation. And therefore, it is very important to keep that in mind before you say that your patient has acidity or gas or some nonsense diagnosis. Very often it gets confused. People, very casually say, no, nahi, kuch nahi, just कल रात को मैंने बहुत ज्यादा चिकन खा लिया था उसके बाद ऐसा होने लग गया, right? So it is acidity. Patients sometimes tell that to themselves. Unfortunately, sometimes we also get confused and we feel, okay, nahi ho sakta acidity hai, right? So please make a note of this. A burning sensation, which is also known as heartburn, so it might get confused with acid peptic disorder. So please make a note of this. Heartburn is the word we use for acid peptic disorder, but this burning sensation can get confused. So please make a note of this, that consider acid peptic disorder as a differential diagnosis of angina, right? It's not true to say that the pains are different. They might sound very similar and you might be very confused. If you are confused, you might as well admit the patient or at least get an ECG done or get the evaluation done. Don't send him back clinically. I thought it was heartburn. I thought it was acid peptic disorder. Don't do that, right? If you are confused, if the history is not very clear, evaluate the patient. That's always the rule, right? So the patient might complain of a crushing sensation. The patient might complain of heaviness. Patient might complain that I have a burning sensation. Some other words that the patient might use are, patient might say that I had a squeezing sensation as if koi marod raha hai. So patient will say that I have a squeezing sensation. Right? Rarely, not rarely, but uncommonly, patients might say I have a stabbing sensation, that someone has pierced with a stab or stabbed inside the chest. So sometimes they might say that I have a stabbing sensation. So different words are used by the patient. One patient might have one type of description, another might have different type of description. So you need to be aware of all these descriptions that the patient has. The one part where I feel a lot of us do get confused is the burning part. When they say burning sensation, it's not common. But if they say that, we get carried away and thinking, oh, burning sensation, well, this should be acid peptic disorder. It might be a reflux. Not really true, right? Take the right history. Under the right context, it might be coronary eclampsia, or it might be a angina, right? Very frequently, there could be other associated features. So please make a note of this. Patients could have other associated features with angina. One is all those angina equivalents. So they might have angina accompanied with dyspnea, accompanied with palpitation, accompanied with syncope. So they might have associated features which are angina equivalents. So angina, we are describing it and we are saying it could be associated with angina equivalents. That might help you to pick up the diagnosis. Another thing is sweating. Patients might have profuse sweating when they have angina. So they might tell you that at that time, I started sweating. Profuse sweating at the time when angina starts. Some people might report to you saying that when this happened, my extremities went cold, right? So they might tell you that either they were sweating, sometimes they might tell you that I was sweating and मैं ठंडा पड़ गया था, हाथ पैर ठंडे पड़ गए थे, that my extremities go cold when this happens, right? They might have all these symptoms. And in very severe cases, patients who have angina might say that they have a feeling of impending doom. Feeling of impending doom is a big way of saying that the patient tells you, I feel something bad is going to happen. When this happens, there is something where I feel that I am going to die, right? A feeling of impending doom along with this sensation of chest pain. So please make a note of this. This might be a very severe marker. When patients say something like this, very often the symptoms have been prolonged and long lasting. A patient with just simple angina wouldn't say impending doom, but a much more severe case, someone who is having infarction, might have a prolonged angina and might come up telling you that I feel right now I'm having this chest pain and I feel I'm not going to survive, right? Always take that patient seriously. If a patient tells you that I feel something is going to happen to me, right? Don't brush it off and say, nee, all my tests look fine, nothing will happen to you. Don't do that mistake. We have done those mistakes and we have realized that patients are very often right. Our science is not complete. We don't understand what is really happening. I'm not sure even they understand what's really happening, but they do understand something bad is coming. That sensation, if the patient tells you, if he verbalizes that, pay attention, pay your respects to that sensation, and be very meticulous in searching what is happening behind. Right? It could be MI, it could be something else. Right? But the feeling of impending doom, if a patient has uttered that to you, if he has told you or she has told you, I feel something bad is happening to me, stay with that patient. Something bad might be happening which you are not able to figure out. Right? Don't brush it off saying कुछ नहीं हो रहा तुमको, ठीक है? Okay, so this is where we are describing angina. We are describing what is the kind of clinical features of angina. What I have nicely skipped out of this is the time, right? I have not told you the time of this, how long is this going to last, because that will depend on what kind of a presentation the patient has, right? So angina, the time duration will change whether we are looking at one particular disease or another particular disease, right? Okay. Now, what I'm going to do is I'm going to hold on at this point. I have described a lot of things. Please go through them again. And if there are questions, please put them across. After this, I'm going to move towards how do we classify coronary artery disease, another important heavy duty section. So before we go there, we need to be sure that we have understood what I have said till now. I have described what is the overview of coronary artery disease patient presenting to us. There is still a classification remaining, which will give you further understanding of within this, how is the presentation. We have just told you what the symptoms are right now, but how further is the presentation, right? So I'd like to take your questions. When you send me the questions, ensure that you are sending it in the chat box, and in the chat box, ensure that you have changed your settings to panelist and attendee so that everybody else is also able to see your question, right? So I'm going to hold on at this point and take your questions. Do not put it on your WhatsApp groups. I am over here, so please put the messages. So one of you have messaged me that I'm not audible. So now please tell me, am I audible right now? I'm sorry, I'm seeing that message right now. I'll change the position of my microphone. Okay, am I audible now? So, Dhairishil, are you still there? Uh, okay. Okay, so one of the question I'm getting is during history taking, what are the points that will differentiate CVS versus RS? Okay, so not really a part of this discussion, but now that there is a question, I'm just going to briefly touch that answer because this is not a part of coronary artery per se. This is more of a question relevant to heart failure because that is what you might confuse, but easy to understand. When I'm talking about cardiac symptoms, I would have associated features that you have just now written down. So dyspnea with angina, with palpitation, with syncope, with fatigue, all goes towards cardiac side. When we talk about pulmonary symptoms, then along with dyspnea, that is where the confusion really is. So along with dyspnea, the patient would have other features like cough, fever, expectoration. All those features go towards pulmonary side. Patients having past history of angina, past history of hypertension, diabetes goes towards cardiac side. Patient having past history of tuberculosis, patient having recent past history of pneumonias, asthma in childhood, all those goes towards pulmonary side. The patient, of course, having echo findings goes towards cardiac side. Patient having X-ray findings more often goes towards pulmonary side. So this is the overview. Hemoptysis, again, I forgot that, goes towards this side. On examination, having features like lymph nodes goes towards the pulmonary side. Think of TB. Patients having features like raised JVP, patients having S3, S4 goes towards cardiac side. Right? Murmurs, of course, go towards cardiac side. So in a nutshell, I'm trying to tell you that answer. It's not really part of the discussion of what I'm discussing right now, but overall, these are the differences. Right. Can a patient having acidity have the feeling of impending doom? Unlikely. So I wouldn't associate, if the patient tells me that I have a feeling of impending doom, I wouldn't associate that with acid peptic disorder. I would say that this is something more severe. It could be a cardiac event, it could be an angina, it could be an arrhythmia, it could be something else, not acidity. I wouldn't leave it at that. Right. The pain caused by angina, is it because of excessive spasm or decreased blood supply? The pain caused in angina is because the myocardium is undergoing ischemia or infarction, and the pain, the nerve endings within the myocardium are the ones which are the source of this, right? So it is not the vessel which is causing it, it is the ischemia which is causing it. The myocardium and the surrounding pericardium, that is what is getting ischemic, and that is what is the cause of pain. What is silent angina? So that's a good question. So those of you writing this down, please make a note of this. Thank you so much, Quest Medicine, for asking this question. So what is silent angina? So silent angina is again something that you would see in a patient of diabetes or elderly patient, and that patient would not have angina but would have one of the angina equivalent, typically dyspnea. So please make a note of this. Silent angina is very similar to this situation that I had mentioned over here, this angina equivalent without angina. That without angina means silent angina, but silent angina more specifically is something I use when the patient has dyspnea, and typically in these two cases. Right? So it's you might say this is the same. This without angina wala having only angina equivalent, you might say that is the same as saying that the patient has silent angina. But when you are asked this question in the exam, what the examiner is watching out for is, do you understand that diabetics present with that, and do you understand that elderly patients present with that? Any other questions? Okay, so I'm glad this is working. Okay, fine. So with that, let's move one step ahead. Let us move now towards understanding what is the classification of coronary artery disease. But to understand the classification of coronary artery disease, there is one limitation in our discussion right now, that I have not discussed ECG with you. So I'm going to kind of ask you to not bother too much about the ECG findings right now. When we discuss ECG, you will have these understandings again. So again, it's not possible to teach any one part without not teaching the other part. For example, teaching heart failure without coronary artery disease is limited. Similarly, teaching coronary artery disease without ECG is limited. But when I go there, again, there's a limitation that not teaching this again hampers it. So we have to take a trade-off when we are going in a linear fashion. When you read it, of course, you need to have the understanding of all of these things together. So for today, I'm going to say I'll dictate you the the ECG findings of coronary artery disease. I'll tell you the interpretation of it, but I wouldn't explain it today. You can write it down, and for explanation, I will ask you to wait till the time we have discussed ECG per se. And at that time also, if you have any doubts, we can always clarify them, right? So I'm going to dictate what are the findings of ECG, and I'm going to ask you to kind of today take it in a ride and say, okay, ऐसा होता है, बोल दिया तो ऐसा ही होता होगा, right? Why does it occur? We will wait for that later, right? So we are going to try to understand classification of coronary artery disease with its associated pathophysiology. So please make a note of this: classification and pathophysiology of coronary artery disease. Classification and pathophysiology of coronary artery disease. Now please start on a new page, and I am going to kind of draw a flow chart on one of the page, and I'm going to draw diagrams on another page, and I would want you to kind of follow it in that sequence, right? So when a patient comes to us with coronary artery disease, I'm starting with the classification on one page, and I would be drawing the pathophysiology diagrams on another page. So when a patient comes to us with coronary artery disease, we know that now the patient is going to come to us with these symptoms. The symptoms are known to us: angina, dyspnea, palpitations, syncope, fatigue, right? The question that is really in my mind is, when the patient has come to me, what has caused this? That has been, I mean, what has caused this is the narrowing. Sorry, what has caused this is narrowing, but how severe is it? Is it that my patient is going towards a gradual onset disease, is more of ischemia, or is it like a sudden onset severe disease, is more of infarction? Because the prognosis depends on that, right? So when a patient comes to me with coronary artery disease, I can have two types of presentation. So please make a note of this: when a patient comes to us with coronary artery disease, I can have two types of presentation. One would be a presentation where the patient is going to come to me with sudden onset symptoms. So whether it is angina, whether it is dyspnea, palpitation, syncope, all of it, one of it. But right now, let's stick to angina. So the patient might have sudden onset angina. The symptoms are going to be severe. When I say severe, that means they could be present at rest. So they started on exertion, but they are present even when the patient is resting. They could be prolonged. When I say prolonged now, that means typically lasting for more than 10 minutes. So the patient could have symptoms which are sudden onset, which are severe, which can be present at rest, or which might be prolonged, lasting for more than 10 minutes. And a very important thing for the patient is these are unpredictable. Patient does not know what is going to happen. Patient feels that this is never happened before, or that I don't know how this is going to go, maybe I'll die, whatever. The patient has unpredictable. We'll see what predictable looks like, but understand at this point that the patient says that I have severe chest pain, it is sudden onset, it has lasted for more than 10 minutes. You believe this is coronary artery disease because you have taken the other symptoms and it fits into angina, and that is a patient which has a prolonged angina at rest, unpredictable. This patient very often is going to have hemodynamic compromise. This patient very often is going to have hemodynamic compromise. And when I say the hemodynamic compromise, I am looking at two aspects. Either the BP is going to be low, or the patient is going to have features of heart failure, that is dyspnea. Or it could be both, right? So the patient very often is going to have hemodynamic compromise. That means either the BP is low, forward failure, or the patient has dyspnea, backward failure, hemodynamic compromise. Under such circumstances, a coronary artery disease which has present in a sudden manner, right? The history is going to be that I was fine till some time back, and all of a sudden this has happened, right? This is called acute coronary syndrome. Please mark this word as important: ACS, right? Very important word for us, a very important operational word for you tomorrow when you're in the emergency wards. Remember, you have not required any investigation to do this. You just required the blood pressure and you took a good history. And based on that, you could say that your patient has acute coronary syndrome. right? Acute coronary syndrome. While on the other side, you have another presentation. This is a patient who doesn't have a sudden acute presentation, right? This is a patient who has a long history. The patient has a long standing history. When I say long standing history, it means the history is of few months. That doesn't mean the pain has lasted for few months. That means the history, the onset of all of this is not yesterday, it's not today, it's been there for 3 months, it's been there for 6 months, whatever that the patient is complaining. This patient very often has angina on, or I should write it in capitals, angina on exertion. The patient very often has angina on exertion, but which is relieved on rest. So the angina goes away on rest. So the patient has angina on exertion, which is relieved on rest. Here the patient has a pain which is continuing at rest, or it has been prolonged. Here the patient has angina on exertion, which is relieved on rest. The patient has multiple such episodes. So he has not come to you saying that this is the first time it occurred, but he has had such multiple episodes, and all the episodes were predictable. Predictable means he tells you that I know if I sit down, it will go away. Right? I know if I rest, it will go away. I know if I take that nitroglycerin tablet, it will go away. So it is predictable. And typically, he knows that the pain would go away in a span of 2 to 5 minutes. Very important difference. Here it is going to last for more than 10 minutes. It might even go half an hour or 1 hour, but at least crossing 10 minutes. And here it is going to go away in 2 to 5 minutes. He could have angina, he could have angina equivalents. That is same in both cases, but the severity is more, it is unpredictable. Here it is predictable. The patient knows, okay, if I stop walking, it is fine. The patient will tell you that, doctor, the last 6 months, whenever I go for the morning walk, after walking for some time, I have to rest. But what happens when you rest? Well, after I rest, the chest pain goes away. Then what do? I walk again. He's not dying. He's not even bothered that he's going to die immediately, right? He's telling you that I've been having this symptom. In fact, if you are able to imagine these two cases, this is a patient. The first scenario is a case. The first scenario is a case who must have been rushed to you in the emergency. He has 1 hour history, 2 hour history, and this is a case who is coming to you casually in your OPD and saying, "Oh, this has been happening for the last 6 months." Right? This kind of a presentation is going to have very often a hemodynamic normal status. So please make a note of this. The hemodynamics are going to be fine. This patient is going to be hemodynamically stable, is what I might say. This is a hemodynamically compromised or unstable patient. This is a hemodynamically stable patient. Blood pressure is not low. The patient does not have dyspnea, acute dyspnea when he's presenting. Such a presentation is called, remember, this is a patient who is stable and who has angina, which is long standing. That gives you a clue to the name of this disease. This is called chronic stable angina. Chronic stable angina. Right? Now remember here, the word angina doesn't really reflect these symptoms. He would have dyspnea also, but chronic stable angina is the name of this disease. Chronic stable angina. Right? So I want you to understand that there are, in broad strokes, two presentations of coronary artery disease. Patients can either present to you with acute coronary syndrome, or the patient might present to you with chronic stable angina. Remember, this differentiation is based on clinical features. It is not based on any investigation. Based on clinical features, you are able to differentiate whether you're looking at the patient on this side or you're looking at the patient on that side. Right? No investigations required at this stage. You could have acute coronary syndrome or you could have chronic stable angina. Right? Now it is easy to understand why this is happening. So let's go in towards the pathophysiology. Now please keep this page intact. Do not write on this page. I am going to open up a next page where I'm describing the pathophysiology. So please make a note of this. What is the pathophysiology? What is happening behind the scenes? Why is the patient presenting to me this way? Please understand, please make a note of this. In chronic stable angina, the disease has been there for a long time, right? So it's a slow, progressive narrowing of the blood vessel. It is a slow, progressive narrowing of the coronary arteries, and this narrowing at the heart of it has atherosclerosis. Right? So there is a slow, progressive narrowing of the blood vessel because of atherosclerosis. So if I say that this is the blood vessel, this is the lumen of the blood vessel, what we know is that inside the lumen there can be atherosclerosis that is gradually growing, and it is narrowing the lumen, and then the patient is having a decrease. Because of this, there is a decrease in supply. Because of the decrease in supply, there is going to be some symptom, right? Now the first question is, now do not write this part, when did the atherosclerosis start? So the patient is typically come to me at maybe 50-55 years age. We have said that that's where most of these patients are going to come to us. But did the atherosclerosis start, if he is, let's say, 55-year-old, did the atherosclerosis start yesterday? Not really. He has the symptoms of 6 months. So did it start 6 months back? Not really. When did the atherosclerosis start? In all possibility, the atherosclerosis has started when he was your age, 20s. So please make a note of this, that atherosclerosis of the coronary arteries typically starts in the 20s. It can start earlier also, right? With our changing lifestyles, there is a chance that it might start even earlier. But typically, this atherosclerosis has started quite early, at the age of 20s, right? But the patient has presented to you at the age of 50s, which means that even if there was atherosclerosis around, it never caused symptoms to you when you were 30 or 40-year-old. It caused symptoms when you were 50-year-old. That means mere atherosclerosis is not sufficient. To cause symptoms, it should cause narrowing of the lumen. It should narrow down this lumen furthermore. How much of a narrowing do I really require, right? So if I say that of the whole lumen, it has maybe right now narrowed to 20%. 80% is patent, 20% narrowed. Do you think the patient will have symptoms? Unlikely. Let us say I narrow it down further to, let's say, 60%. Do you think the patient would have symptoms? Well, now you will say only this much lumen is patent, this is gone. Possible that the patient has symptoms, right? So please make a note of this, that atherosclerosis is a progressive disease and symptoms would start only when the coronary artery lumen is obstructed by more than or equal to 50%. So please make a note of this. Symptoms would start when the atherosclerosis has narrowed the coronary artery by more than or equal to 50%. If there is a 40% narrowing, 30% narrowing, 20% narrowing, unlikely that it is going to contribute to symptoms. The patient will be able to do well with the remaining blood supply also, right? But once the lumen has been narrowed to more than 50%, that is when the patient would have symptoms, right? Now, if you keep on increasing the degree of narrowing, if from here, you go furthermore and you cause more narrowing, of course, the symptoms will increase. So please make a note of this. As the narrowing increases from 50% to 75 to 80%, as the narrowing goes on increasing from 50% to 75 to 80%, the patient would have increase in the frequency and severity of symptoms. As it goes from 50% to 75% or 80%, the patient is going to have increase in the frequency and severity of symptoms. The severity of symptoms can be assessed by the same scale that you use to assess dyspnea. Now, I'm not going to ask you to write this down, but I hope most of you have heard about that scale called NYHA, New York Heart Association. That same scale can be used to assess this symptom, right? So, for example, the patient might initially tell you that I have angina only when I jog and go for jogging, right? Not my usual activity, but more than usual activity. Second stage, patient might tell you that I have no symptoms when I do my usual activity. So, for example, if I'm going to for my usual office work, I start having symptoms. But no, it's not always there. It's sometimes. Third stage, the patient tells you that I have symptoms on my usual activity and even less than usual activity. If I have to, maybe walk around in my house or something, I might start having symptoms there also, right? And the fourth stage is when the patient tells you that I can't do any activity without having pain, and I might have pain even at rest. Very similar to NYHA. In fact, you can use NYHA over here as well, right? So please make a note of this. Don't write down the scale, but remember, make a note of this. The scale is something I expect you to know already. So please make a note of this, that the severity of symptoms will increase as more and more artery gets narrowed, and you can assess this symptom by the NYHA, New York Heart Association scale. So when you ask the patient symptoms, you can ask the patient symptoms and you can categorize it according to the NYHA scale. NYHA scale is designed for dyspnea. It can be used for angina also, right? But remember, while this narrowing is occurring, the heart is not going to keep quiet. I mean, this is going to happen over years. Please make a note of this. This worsening from 50% to 75% is going to happen over years. It's not like the patient yesterday was able to walk 200 meters and today is not able to walk 20 meters. That's not what will happen. The patient was able to walk 2 kilometers 5 years back. He is able to walk 2 kilometers maybe till 3 years back also. 3 years back, his symptoms worsened and gradually is now able to walk 1.5 to 2 kilometers. Something of that. The worsening is going to happen over years. But if the heart is going to be ischemic over this period, remember, that means that the patient is also going to have development of collaterals. So please make a note of this. Over years, there's one more thing that will happen to these patients. There is a lot of time, so patients are also going to develop collaterals. Over these years, patients are going to have development of collaterals within the heart. That is why he will sustain well. Even if 50% has been narrowed, 60% has been narrowed, there are collaterals which are supplying the heart. Because there is time. There is, this is a very slow progression, so there is time. Okay. Once the obstruction crosses 75 to 80%, the patient will start developing symptoms at rest. So please make a note of this. Once the obstruction crosses 75 to 80%, that's the time the patient will start developing symptoms at rest. Right? But at all times, remember what we have said clinically. At all times, the patient is going to have symptoms which are angina on exertion. They go away on rest, except when the patient has developed class 4 symptoms, and they are going to be multiple episodes. They are predictable and they are kind of cleared within 2 to 5 minutes. If that is true, that means at all times, do you expect this patient to have infarction happening in the heart or ischemia happening in the heart? Remember, infarction is irreversible. Ischemia is reversible. So what do you think is happening to the heart of this patient? In all possibility, at all these times, the heart is having ischemia. So please make a note of this. Please make a note of this. In all these times, the heart is going to have ischemia, which means there is going to be ischemia which is present, and when he takes rest, the demand comes down, that ischemia is reversed, right? So it is reversible. Right? So I repeat, in chronic stable angina, you have slowly progressive atherosclerosis that is going to gradually narrow down, and the patient is going to have symptoms. The symptoms are going to be of increasing severity over years, and by that time there is going to be development of collaterals, and at all times the patient has ischemia, and this is reversible. If you look at the myocardium closely, let's say that this is the myocardial muscle. We understand now, pay attention over here, that this could be the coronary artery. The coronary artery typically comes in and supplies the myocardium, but it does not reach the endocardium. The endocardium gets its own blood supply from the blood which is within the chamber. Right? This side is going to be taken care of by the coronary artery. But when the coronary artery starts narrowing, there is one area which is the most prone to ischemia, which is between this area and this area, that is this part. This part, which is also known as the area below the endocardium or subendocardial area. right? So please make a note of this. When a patient has coronary artery disease causing chronic stable angina, that patient is going to have ischemia in the subendocardium. Subendocardial ischemia. So please make a note of this. Patients having chronic stable angina have subendocardial ischemia. Patients having chronic stable angina have subendocardial ischemia because this area is getting well supplied by the artery. This internal area is getting supplied by the blood within the chamber. This area is the watershed area. It is no man's land. Usually it will get its blood supply, but when the artery starts narrowing because of any reason, this is the first area to get affected and the patient has subendocardial ischemia. Right? बट ये सब एंडोकार्डियल इस्कीमिया कब हो रहा है पेशेंट को? When is the patient having subendocardial ischemia? Is it constantly happening or is it only happening when the patient is exerting? Well, this is happening only when the patient is exerting, right? So please remember this, the subendocardial ischemia is on exertion. The patient of chronic stable angina has subendocardial ischemia on exertion. At rest, this area gets its blood supply. The demand has come down and the supply is met. But when the demand goes up, this area starts receiving less than what it requires and develops subendocardial ischemia. Right? Now, the one thing which I would want you to remember and know, I am not going to explain it at this time, is please make a note of this. On the ECG, please make a note of this. On the ECG, subendocardial ischemia is represented by ST segment depression. On the ECG, subendocardial ischemia is represented by ST segment depression, right? And in the case of chronic stable angina, remember ST segment depression will occur whenever there is subendocardial ischemia. But subendocardial ischemia is happening on exertion. So that means in a case of chronic stable angina, I expect to see ST segment depression on exertion. So please make a note of this. In a case of chronic stable angina, we expect to see ST segment depression on exertion. Whenever the patient starts exerting, if you do an ECG at that time, the ST segment will be dropped down. It will be ST segment depression. Right? If that is true, tell me, if I get a patient of chronic stable angina, that means if I get a patient who is telling me these symptoms, that I have long-standing history, 6 months, I have angina and exertion, it goes away on rest, I know it will go away in 2 to 5 minutes. The patient has come to me and he's sitting in front of me. When the patient is sitting in front of me, he has come to my OPD. I ask him, sir, madam, do you have chest pain right now? He'll say, no, right now I don't have chest pain. I'm sitting, no, so I won't have chest pain right now. If you ask me to walk, after some time, I will start developing chest pain. If I do his ECG right now, that's how the patient has come to me, right? If I do his ECG right now, at rest, when he doesn't have symptoms, do you expect the ECG to show you ST segment depression? The answer is, of course not, because he doesn't have ischemia right now. If I want to see ST segment depression, he should have ischemia, but the ischemia is occurring only on exertion, which means on increasing the demand. What's the solution? How can I demonstrate that this patient has ischemia? How can I demonstrate? I would like to see your answers. Are there any solutions here? How do I investigate this patient? Should I do his baseline ECG? If not baseline ECG, what should I do for this patient? It's quite a logical answer, but let's see what you think. So my question is, at rest, the patient is going to have no ECG changes. But if I want to say that my patient has chronic stable angina, I want to show ST segment depression. That tells me there is subendocardial ischemia. How do I do that? Yeah, most of you have written the exact perfect answer right now, right? So of course I need to get him to exert. How do I get him to exert? I get him to exert by, in my hospital, running on a treadmill, and that is called a treadmill test. And I'm putting the heart under stress, so it's also called a stress test. And I do an ECG at that time, And at that time, I find that the ECG shows ST segment depression. Wonderful. So please make a note of this. Please make a note of this. Thank you so much for your answers. Please make a note of this. That go back to this page and please make a note of this. That since these patients have ECG showing ST segment depression on exertion, a patient of chronic stable angina, the test that you're interested in is called the stress ECG, also known as the treadmill test. Standard abbreviation is TMT. Both mean the same. Treadmill is that thing that you run on, and ECG has been done under stress, so you call it, both of them are the same. And while doing this, you will be able to demonstrate that the ST segment has been depressed. At baseline, when you start the test, the ST segment would be normal, but as the patient runs, the ST segment will depress. There is a specific term that we use to describe this phenomena, that the ST segment will go down when the patient starts exerting. We say that this patient has demonstrated what is known as inducible ischemia. That means you can induce ischemia in this heart by making the patient run. Right? Remember, when the patient rests, if I make him run, the ST segment will go down. If I make him rest, the ST segment will come back to being normal. That's described as inducible ischemia. If you have ever read the report of a stress test, you will find that the test doesn't say that the patient has coronary artery disease. The test report of a stress test report is almost always said as the patient has inducible ischemia or the patient does not have inducible ischemia, whatever it is. They don't say that the patient has coronary artery disease. They tell you whether the patient has inducible ischemia or does not have inducible ischemia. Right? So I hope this is clear that these patients are the ones who have ST segment depression when they are under stress, and the problem for these patients is atherosclerosis. Right? The problem for these patients is atherosclerosis. Now, please make a note of this. Please add it over here. Please make a note of this. In some cases, especially this one, please make a note of this. In some cases, patients of chronic stable angina might progress such that the coronary artery has more than or equal to 80% obstruction. Right? In some cases, patients of chronic stable angina would progress such that the coronary artery disease has more than or equal to 80% obstruction. When such a thing happens, there would be change in the patient's presentation. Remember, the earlier presentation was that the patient was having this very nice predictable angina on exertion, relieved on rest, multiple episodes which were predictable and all of that. But the moment that the patient has more than 80% obstruction, that is this scenario, there's going to be a change in the patient's presentation. And the change is going to be that the pain would start occurring at rest. The pain will start increasing in severity, what is known as crescendo pattern. Typically, there will be an increase in severity over a span of around 1 month or 4 weeks. So in the last 1 month, my severity has gone up. That is what he will tell you. The moment it crosses that 80% mark, patients will start telling you that I have chest pain, and that earlier, I used to walk and it used to go away. Now it doesn't go away. I still have it on rest. Earlier, the pain was not so severe. Now it has become very severe. And in the last 1 month, the severity has been increasing. I feel more pain now than I used to feel earlier. That is a crescendo pattern. And it will typically start crossing 10 minutes. Now remember, the patient still started with chronic stable angina, which means the patient basically had atherosclerosis. But that atherosclerosis now has progressed too far. Now I can't say this patient is stable. This condition has a different name. Please make a note of this. This situation is called unstable angina. This patient is said to have unstable angina. Right? This patient is said to have unstable angina. But this unstable angina, please make a note of this, has basically ischemia at rest. This unstable angina has ischemia at rest. Right? Ischemia at rest. Now, I would want you to remember this unstable angina for some time. I'm not going into the details of unstable angina right now. I would want to kind of get back to unstable angina in some time. But for now, let's keep it just where it is, right? Let's just keep it wherever it is. This is a patient who has come to me with symptoms at rest. This is a patient who has increased severity. He tells you that I'm not feeling well, that the symptoms are now lasting for more than 10 minutes whenever they occur. They can occur at rest, they can occur on exertion, but when they occur on exertion, they last for more than 10 minutes, even if I start taking rest. So when I'm resting, I still have symptoms, right? We'll come back to this idea of unstable angina in just a short while. But now let's move towards the other part of the story. Please make a note of this. What is the pathophysiology happening in patient of acute coronary syndrome? What is the pathophysiology when I'm dealing with a patient of acute coronary syndrome? Acute coronary syndrome. That was chronic stable angina that we saw earlier. What is happening in the case of acute coronary syndrome? We know that acute coronary syndrome is a patient who came to us. The effect of whatever is going to happen in the heart is sudden. The patient will tell you, I have 1 hour history, 2 hours history, whatever. A very short history is what the patient has come to us with. The symptoms are at rest, right? Now, in case of acute coronary syndrome, the disease is not atherosclerosis alone, right? Now, please have a look over here. Let us say that this is the coronary artery. Within the coronary artery, let us say that this is the area of atherosclerotic plaque, but it is not a plaque which is more than 50%, it is less than 50% plaque, right? So I'm keeping it less than 50% in this example so that it is not the cause of your symptoms. Now, when we look at a plaque, when we look at an atherosclerotic plaque, we do know that at the center of the plaque, you have a lipid core. At the center of the plaque, you have an area which is the lipid core. And on that lipid core, you have an area which is known as the fibrous cap. So this is the fibrous cap, this is the lipid core. And this fibrous cap is surrounded by endothelium. Inside over here, you have the RBCs. This is the area of the blood vessel. This is the area of the plaque. This is the area of the blood vessel. Now, do not write, but understand. Normally in our blood vessels, while the blood is flowing, it does not form clots. It does not form clots within the blood vessels. One of the reason for that is the endothelium. The endothelium has an anticoagulant action, and because of the action of the endothelium, the blood does not clot while it is flowing through the blood vessels. Okay? But the lipid core that we have just now seen, the lipid core which is right now within the wall of the vessel, that lipid core is procoagulant. It's not anticoagulant, it's procoagulant. So if I have a look over here, this lipid core is procoagulant. The endothelium which is covering, and right now which is also covering the fibrous cap, is also anticoagulant. But this thing is procoagulant. In some patients, now who are these patients? These could be patients who are smokers. These could be patients who are hypertensive. These could be patients who are diabetics. Top 3 causes. So in some cases, now please start writing with me. In some cases, like patients who are smokers, diabetics, hypertensive, etc. These are not the only one, but these are the top ones, especially smokers and diabetics. These patients have a rupture of this plaque. So please make a note of this. In acute coronary syndrome, one of the primary problems is that these patients have a rupture of the fibrous cap. Because there is a rupture of the fibrous cap, there is exposure of the lipid core towards the blood vessel. So please make a note of this. There is a rupture of the fibrous cap, and this exposes the lipid core to the blood. Exposes the lipid core to the blood which is flowing through the blood vessel. This lipid core please remember, is procoagulant. This lipid core is going to be procoagulant. This procoagulant lipid core is going to now activate two things. One, it is going to start calling for platelets. So one thing that will happen now is that this lipid core is going to start calling for platelets. These platelets will come and they will start trying to plug this area, right? So platelets will come and they will start trying to sit on this area. That is going to be called a platelet plug. So there is going to be a platelet plug. The platelet is going to come and it is going to start plugging this area. Right? Now, when the platelets start plugging this area, there are also going to be other markers which are going to be cytokines or chemicals which are going to be secreted at this area, like ADP, like thromboxane A2, like serotonin. These are all being secreted by the damaged endothelium. So please make a note of this, that when the platelet plug is formed, the damaged endothelium is also secreting other markers like ADP, thromboxane A2, and serotonin. Together, this is helping activate certain receptors on the platelets, known as receptor glycoprotein 2B3A. So the patient is going to have platelets coming over here, and these platelets are going to get activated. We say that the platelets have got activated by these markers which are secreted by the damaged endothelium. And the activation means that there is activation of these receptors known as glycoprotein 2B3A. This platelet receptor, glycoprotein 2B3A, basically helps the platelet to bind to two things. It helps the platelet to bind to other platelets, and it also helps the platelets to bind to fibrin. It helps the platelet to bind to other platelets, and it also helps the platelet to bind to fibrin. Right? So one thing that will happen is platelet plug started forming, and you started causing activation of platelets by using markers like ADP, thromboxane A2, and serotonin. Right? But on the other side, there was also activation of the coagulation cascade. There is also activation of the coagulation cascade. And the end result of this activation of coagulation cascade is that there is formation of fibrin. There is a formation of fibrin. Fibrin is like a strand. So you have fibrin strands which are being formed. And now you have a situation that you have a platelet which can bind to the fibrin strand and can bind to each other. If you understand what this is going to cause, well, this is going to cause the formation of a clot. So all of a sudden you have a situation that you had few platelets over here. Over time, next few minutes, few hours, you started getting fibrin over here. And over time, you started having more and more platelets coming in, more and more fibrin coming in, and that started forming a progressive clot. A clot, or also what you call a thrombus. Now understand, in the previous scenario, you had no such thing in the blood vessel. Here, you have what is known as formation of a thrombus. So please make a note of this. Please make a note of this. Platelets and fibrin together lead to formation of a thrombus. This is a new thing which did not occur in chronic stable angina. It is happening over here. Atherosclerosis is not the cause of, or at least the prime cause of acute coronary syndrome. It is a contributing factor, but the prime cause is this sudden onset thrombus. The prime cause is a sudden onset thrombus, right? This thrombus typically would be built up within a span of minutes to an hour. Within a span of minute or an hour, you will have a clot which is developed over here. So the presentation is going to be very acute, right? But now let's put this in context. This thrombus is happening within the blood vessel which is supplying the myocardium, right? So you have this blood vessel which is supplying the myocardium and it is going in like this, right? And this thrombus that we are talking about is happening inside this. Now it depends ki what kind of a thrombus did you form. If for instance, the thrombus that was formed was such that it completely obstructed this blood vessel. If the thrombus that was formed was so big that it completely obstructed the blood vessel, if the whole thing was gone, then there will be no blood supply to that entire myocardium. If it was an obstructive thrombus, the first possibility is if this was an obstructive thrombus. Oh, sorry, I'm sorry, not obstructive, occlusive thrombus. If it was an occlusive thrombus, and when I say occlusive thrombus, I mean near 100% occlusion of the artery. That means the entire myocardium is going to suffer from ischemia and within no time infarction. So please make a note of this. If there is an occlusive thrombus, then what I expect to see is a transmural infarction. If it is an occlusive thrombus, there is no way that there is any blood supply coming here. So if there is an occlusive thrombus, if you have completely blocked the artery, I expect to see transmural infarction. This is the worst thing that can happen to the patient. And transmural infarction on an ECG, remember subendocardial ischemia on an ECG was showing? Now this is something I want you to remember, that subendocardial ischemia on ECG was showing SC segment depression. But if there is a transmural infarction, the whole myocardium is dead because there is no blood reaching there at all. You have completely blocked the artery. The transmural infarction on ECG is reflected as ST segment elevation. So please make a note of this. This transmural infarction on an ECG is seen as ST segment elevation. And that gives the name to the disease. This disease is called ST segment elevation myocardial infarction. So please make a note of this. The worst thing that can happen to the patient as far as coronary artery disease goes is that you have a thrombus formation which happened over minutes, and within those minutes you had a completely occlusive thrombus. There was no time for collateral, there was no time to save anything. The whole myocardium was jeopardized and that entire myocardium has infarcted. That is called ST segment elevation, because that's what my ECG shows, myocardial infarction. ST segment elevation, myocardial infarction. Right? So if I go back to my first page where I was drawing the schematic diagram, I know that one of the consequence of acute coronary syndrome, one of the outcome of acute coronary syndrome is that I might have an ECG showing ST segment elevated. If my ECG is showing ST segment elevation, I know that I am looking at transmural infarction, and the name I give to this disease is ST segment elevation myocardial infarction. So please make a note of this, that ST segment elevation MI or STEMI is one of the type, the worst of it, of acute coronary syndrome. Right? I have a completely occlusive thrombus, the artery is completely closed. Unless you do something about that thrombus now, there is no way of saving the heart. This is the topmost of the emergency, right? So this is the topmost of the emergency. There is going to be a high mortality rate with this, and the patient is going to die if you don't stop this heart from going away. The entire wall is gone. The entire blood supply to the wall is gone. That entire wall is not going to function. If this was an important wall, if this was the free wall of LV or the interventricular septum, the patient would have dire consequences. Right? But then body has its own protective mechanism, right? So it's not necessary that all patients have a completely occlusive thrombus. Some patients might have a thrombus which is growing, but the body's anticoagulation activity is able to keep it in the check. That you do have a thrombus, but it has not completely blocked up the entire artery, right? That scenario is a non-occlusive thrombus. So please make a note of this. You can have a scenario where you have a thrombus, but that thrombus is non-occlusive. That means it has caused a blockage of the artery, but the blockage of the artery, which is all of a sudden by the thrombus, not by atherosclerosis, the blockage of the artery, the total lumen has been narrowed, but the narrowing is not 100%. In such a case, the patient would still have infarction, but in such a case, the infarction doesn't need to be of the entire area. It will be of the most vulnerable area. Which is the most vulnerable area? Well, the most vulnerable area, as we know from our previous discussion, the most vulnerable area is subendocardium. So if the blockage is not 100%, the first area to die is this. More area would die, but not the entire myocardium. But the first to die is this. So this patient is going to have subendocardial infarction. Now remember, it's not necessary that it is limited to the subendocardium. It can spread, but he doesn't definitely have transmural infarction. If the patient has subendocardial infarction, please understand that means the patient might have ST segment depression, but what is more important for me is that he does not have ST segment elevation, right? He might show ST segment depression, that's good, but what he will not show is equally important. He will not show you ST segment elevation. This kind of a presentation is what is called non-ST segment elevation myocardial infarction. That ST segment elevation is so important for me that it helps me to differentiate in two diseases: ST segment elevation MI and non-ST segment elevation. Right? It could be ST segment elevation MI or it could be non-ST segment elevation MI. Right? So depending on whether I'm looking at a clot which is occlusive or whether it is non-occlusive, I can further differentiate whether it is ST segment elevation or non-ST segment elevation MI. Right? So if I come back over here, if I come back to the diagram where we are trying to differentiate and make that classification, if I come back over there, I can say that a patient, when he comes to me or she comes to me with acute coronary syndrome, the test I'm going to do is ECG. And on ECG, if I see ST segment elevation, I know straight away that I'm dealing with ST segment elevation MI, that there is a transmural infarction because of a non-occlusive, or sorry, because of an occlusive thrombus. But I can also say that if my ECG does not show ST segment elevation, if my ECG does not show ST segment elevation, right? It might show ST segment depression. It might even be normal actually, but it might show ST segment depression. But what is more important for me is that it is not showing ST segment elevation. Then, well, then what? Can I say that my patient then directly has non-ST segment elevation MI? Let me think through. Let me think through. Stay with me at this point. Stay with me at this point. We are dealing with a scenario now where I have got a patient who came to me with sudden onset symptoms. The symptoms have been prolonged more than 10 minutes. The symptoms are severe. The symptoms are at rest. The patient says this is a recent finding. He may not have a blood pressure which is high or low, or rather, may not have a blood pressure which is low, or may not have dyspnea. I do an ECG. If I would have found ST segment elevation, I would say this is ST segment elevation MI. Clear enough. But if I don't find ST segment elevation, forget whether I find ST segment depression or not. If I don't find ST segment elevation, then one possibility is, well, it is a thrombus and that thrombus is non-occlusive, but it is still a thrombus and it is a non-ST segment elevation MI, which means that there is infarction. But isn't there another possibility? Isn't there another possibility which we had left some time back? That this patient could also be a patient who was in the past having chronic stable angina, but that chronic stable angina has progressed so much that he has symptoms at rest. Well, that is what my patient has severe symptoms. That is what my patient has has symptoms lasting for more than 10 minutes. That is what my patient has. And yet, the ECG will not show me ST segment elevation. Is it possible that what I'm dealing with is not NST segment elevation MI or non-ST segment elevation MI, but it could be an unstable angina? Possible? Possible. Na? On this much information, when the patient came to me, pay attention again, on this much information, when the patient came to me, that the patient has acute coronary syndrome with no ST segment elevation, I actually cannot be very sure whether I'm dealing with non-ST segment elevation MI, which means there is an infarction, or am I dealing with an unstable angina, which is a worse form of chronic stable angina? Well, unstable angina can't be put over here, right? It has to be put somewhere here. But I don't know on the basis of ECG whether these two are different. So what I do is I actually club them together as a syndromic diagnosis. So please make a note of this. My working diagnosis, when I see a patient like this, please make a note of this. My working diagnosis at this time is I actually say that my patient has non-ST segment elevation MI oblique unstable angina. Your diagnosis at this time is going to be written on paper as NSTEMI oblique UA, right? Please make a note of this. At this point, you do not have enough information. If the patient has come to you and you're trying to classify what is it that my patient has, you do not have enough information to say whether your patient has NSTEMI or whether your patient has unstable angina. NSTEMI means infarction, a non-occlusive thrombus. Unstable angina means more than 80% obstruction because of atherosclerosis, predominantly ischemia, maybe some infarction, but predominantly ischemia, right? But the ECG in both cases does not show me ST segment elevation. It might show me ST segment depression. It might be normal also. Remember, in up to 1/3 cases, you might want to write that over here, right? In up to 1/3 cases, the ECG here could be normal, right? 1/3 cases, normal ECG. The question is, how do I differentiate these two? How do I differentiate these two? Any ideas? You can put up your answer in the chat box. Any ideas? How do I differentiate these two? How can I differentiate whether what I'm dealing with is a non-ST segment elevation MI, that is a non-occlusive thrombus causing infarction, or am I dealing with unstable angina, that is an atherosclerosis which has progressed too far and is causing subendocardial ischemia at rest? Any ideas? How do I differentiate the two? I'd like to see your answers. Is there a way out? Can I differentiate these two by doing some test? Remember, I do a test when I am stuck with a problem. I have a question to answer. Am I dealing with non-ST segment elevation MI or unstable angina? What test would you ask me to do at this point? Echocardiogram. How is echo going to help me? Actually, as we'll see, echo doesn't really help me much. Angiography, maybe, but are you going to do angiography in the emergency ward? Serologic markers, CKMB, that's interesting. Why CKMB? What serologic markers are we talking about? Troponin levels, interesting. Why are we thinking of that? Troponin T. Why are we thinking? Why? Why are you asking me to do that? What are you hinting towards? What are you hinting towards? Why are you asking me to do that? Tell me the why also. Troponin I and troponin T, agreed, but why? What are you trying to do by looking at these markers? So the question is always, why do you do a certain thing? It's not like मेरे को बताया तो मैंने कर दिया, ठीक है? Why did I do it? Why did I do that? So tell me the why. Why do you want to do these tests? I agree, the answer is right. Echo wouldn't help me. Echo wouldn't really tell me whether it's non-ST segment elevation MI or unstable angina. It doesn't differentiate, right? Angiography might tell me, but it's too short a time for me to decide. I have to decide this within 5 minutes. Angiography will take me next 1.5 to 2 hours before I get the angiography, right? So I need the answer right now. But why are these levels being tested? Correct. Wonderful. So you do get this idea that we are dealing with this question of, am I having infarction or am I having ischemia? We know that whenever there is infarction means cell death. If there is cell death, I expect that cell to burst open and release the markers. Those are the cardiac biomarkers. So please make a note of this. Please make a note of this. When I'm stuck at this point, so all of you have answered it correctly. Thank you so much. So when I'm stuck at this point, my next test should be to do cardiac biomarker. My next test should be to do cardiac biomarkers. And the cardiac biomarkers which we do use today are either troponins, sorry, the cardiac biomarkers that we use are either troponins. You can use either troponin I or troponin T, whichever is available at your center. Both are equally good. There is practically no difference between the two. So either of them can be used. You don't need both, either of them. Or you can use creatinine kinase, the subtype MB, creatinine kinase MB. There are other markers also like myoglobin, LDH, but they are no longer used, right? So it's okay even if you don't write them down, right? The ones that are used today are troponins or CPKM, right? Please remember, they might take up to 3 to 6 hours to get positive, right? So you might have to repeat them if you are negative ones. So they might take 3 to 6 hours from the onset of chest pain to get positive. But if I have a situation that the cardiac biomarkers are elevated or positive, I can say my patient has non-ST segment elevation, myocardial infarction. I know it's infarction because these cardiac markers have been released by the heart. But if these cardiac markers are negative, and maybe if I'm having a high suspicion, I repeat them after 3 to 6 hours and they're still negative, I'll say my patient does not have infarction. He seems to have more of ischemia. The diagnosis is unstable angina, right? We are dealing with very interesting scenarios and potentially life-threatening conditions over here. So let's try to understand again. When we talk about coronary artery disease, we are dealing with one of these possibilities. Either the patient has STEMI, or the patient has NSTEMI, or the patient has unstable angina, or the patient has chronic stable angina. In this way, going from worst to the best possible diagnosis for the patient. This is having high mortality, lower mortality, even lower mortality, and the least mortality. Nothing of them is zero mortality. All of them can contribute to death. But this is the spectrum of coronary artery disease, right? I'm going to stop my discussion over here. And if there are questions, I would like to take them. So please go through everything that you have written down today. This is a very, very, very important lecture that can be taken in cardiology, according to me, because this idea about what is chronic stable angina, what is acute coronary syndrome, what is MI. So very often we use the word MI very vaguely. We say that the patient has MI. The patient has angina doesn't mean he has MI. MI is a very specific word that I use for ST segment elevation MI or non-ST segment elevation MI. MI is an event that occurs in the patient's life. Angina is a symptom which can occur once, but it could occur multiple times. Chronic stable angina is again a episodic presentation, angina on exertion, predictable angina. Acute coronary syndrome is an acute event that occurs in the patient's life. The patient never forgets in the rest of his life, and it's not something that you should take lightly if you are mentioning MI, right? If there are any questions, I would like to take them at this point. So with that, I am closing the discussion today, and I would like to take any questions that you have. I'm going to hold on for the next few minutes. Please type them up in the chat box. I would like to take your questions. What is the role of angiography and all of that? We are going to come to that. How do you treat all of this? So the next lecture that we are going to take is actually going to be focusing on ST segment elevation MI. The lecture after that, we'll be focusing on non-SC segment elevation MI, unstable angina, right? So next lecture is going to be about SC segment elevation MI, management protocols. That's the most important part over here. So we're going to deal with that the next time. Any questions, please go ahead. When there is a sudden infarction, what is the mechanism? अरे अभी इतना सब तो लिख दिया आपने. That the whole story of occlusive thrombus, that is a sudden infarction, right? That story that there is a rupture of a plaque, there is a platelet coming there, the platelet getting activated, platelet combining with fibrin, making an occlusive thrombus, that is the sudden infarction, right? Thank you, Quest Medicine. Any other questions? So please use your names, because Quest Medicine is a very generic name right now for me. So it's also an email address. So please do use your names later on. Not now, it's okay, but I'm just saying. Okay, any other questions? Okay. Okay, this is a good question. So pay attention to this question and the answer I'm trying to explain at this point. So the question is, if a patient comes with a heartburn and has risk factors for coronary artery disease, but has no angina equivalence, how do we go about this patient's about this case? Does the patient require admission in this case? So, okay, this is a very difficult question to answer if we go into too much of specifics. So I'll keep it broad stroke. In specific, this is an answer which is still unsettled. Many people are trying to find an answer to what is the exact time when I should hospitalize this patient. I'll keep it simple. The simple answer is, well, if you feel that this patient has a high risk of coronary artery disease, as you have written, better to hospitalize the patient. Even if you do not want to hospitalize the patient, it is better that you keep the patient under observation for the next at least 6 hours. Whatever is going to happen is going to happen in the next 6 hours, right? Either he will worsen or he will improve. So at least for the next 6 hours, keep the patient under observation. So what you have written is the patient has heartburn and there is a high other risk factors are present for coronary artery disease. You just don't have angina equivalent. Doesn't matter. If you believe that that heartburn fits into this idea that it is acute onset, it is severe, it has lasted for more than 10 minutes, and the patient is not very clear. So, you know what, food intake can precipitate angina in a lot of patients. So that food intake, patients might very often tell you, I had a lot of biryani yesterday and after that I'm having this. Don't ignore it. If it has happened, and if you believe that this is the first time the symptoms are out of proportion, do hospitalize the patient or do keep him under monitoring. So my simple answer is, do not leave the patient out of your sight if you have slightest of the doubt that you're dealing with acute coronary syndrome. The real trick is going to be when you don't doubt it, that it was there, but you never thought it, and you thought, oh, this is heartburn, right? That is when you will be in trouble. But if it has crossed your mind that this could be acute coronary syndrome, hospitalize him. Once you hospitalize him, or once you get him to come to a hospital or come to your clinic or wherever you are, what are you going to do? You're going to do two things. So you're going to do an ECG. The ECG, if it shows SC segment deviation up or down, you know your diagnosis. If the ECG is normal, that means it is in that second category, 1/3 of the patients have ECG normal. You are still going to do troponins. If the troponins come out elevated, you have your diagnosis. If the troponins come out normal, you will wait, and if your doubt is still high, repeat the troponins after 3 to 6 hours and see if the troponins elevate. If they elevate, again you have your diagnosis. If all of this does not occur and no new symptom comes, then you might want to discharge the patient after 6 hours. You don't need to hospitalize and keep the patient admitted, but at least 6 hours under observation if your clinical judgment says that this could be acute coronary syndrome. A lot in this rides on your clinical judgment. Test can only confirm or refute what you have thought. If you did not think of it, no one in the world is going to get him to be hospitalized, right? So the question is, in an elderly diabetic having dizziness, fatigue, and hypertension, but no angina, could it be CAD? It can be. So the patient might have. So again, it has to be acute onset, right? It's not like the patient tells you, हाँ पिछले 2 हफ्ते से मेरे को चक्कर आ रही है. 2 हफ्ते से चक्कर आ रही है, आप coronary artery disease सोच रहे हो, आप गलत track पे. Because then you're neither putting him into CAD neither CSA neither ACS. So if it is like कि हाँ मेरे को 1 घंटे से चक्कर आ रही है और साथ में मेरे को 1 घंटे से थकावट भी हो रही है और my blood pressure has shot up, it's possible that you are dealing with acute coronary syndrome. How is the BP in? I didn't get that part. How is the BP in CAD? BP could be high, could be low. It doesn't matter. I have told you that BP high is a risk factor, so the patient could come to you with high BP. The BP low is a result of cardiogenic shock or the heart not pumping. That could be a complication. So both is possible. The patient could be normotensive. The patient could be hypertensive. The patient could be hypotensive. That is not how you decide. You decide on the symptoms. So if you believe that these symptoms are acute onset, you can and you believe that these are angina equivalents in this particular context, the patient tells you कि नहीं मेरे को अभी शुरू हुआ 1 घंटे पहले शुरू हुआ और 1 घंटे से ही हो रहा है, you will be justified in doing an ECG and troponins at that time, right? So again my answer is the same. If your doubt is high, get the ECG, get the troponins. Right? Any other questions? Okay then, so looks like that's what we have for today. If there are any questions, feel free to put them up on the discussion forum or on the groups. That should be it for today. Have a great day and a wonderful week ahead. We'll meet after 2 days. So Wednesday is when we continue with further with SC segment elevation MI. Your gastroenterology assessment is happening this week. The dates I'll put it up on the group. Right. Thank you so much. Okay, thank you. So thank you so much. Have a great day. Goodbye and Jai Hind.